a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
So, good morning, good afternoon, good evening, friends, depending upon which part of the world you are joining us from. I'm Dr. Vijay Agarwal. I'm the president of CAHO, welcoming you to yet another episode of our CAHO-ISQua webinar. And the moderator for today is Dr. Rakesh Gupta. He is the chairman and head of the internal medicine at the Sarvodaya Healthcare in Faridabad. He is a visionary clinician and institution builder. He has led Sarvodaya hospitals, I think, growth from being a modest hospital to today a premier institution, which is recognized today for quality, compassion, and clinical excellence. With over 4 decades of experience, Dr. Gupta has championed patient-centered care, ethical practice, and continual quality improvement. I was talking to him just the other day, and he was one of the first persons to raise his hands that his hospital is going to be declaring they are accreditation ready every single day, and not only on those appointed 5 days. So I really congratulate Dr. Gupta for being very, very forthcoming to promote patient safety and quality. And I now request him to introduce the speaker of the day today, Paul Bowie, who is joining us from Glasgow. And over to you, Dr. Rakesh Gupta. Right.
Thank you, Dr. Vijay, for your very kind words and words of appreciation and encouragement. Good evening, all the delegates, and good evening, Dr. Paul. I'm sure in next few minutes, Dr. Paul will be giving us a very good sermon over the quality. Thank you, ISQua, and thank you, CAHO, for initiating this webinar series. And CAHO is leading the torch of quality improvement across the healthcare in India, and ISQua is leading the torch across the globe. They are doing a UMS job, which is the need of the hour. And with each passing day, we must improve the quality of the healthcare. Friends, you all know that healthcare delivery is a complex subject. Multiple people are working on one single object of delivering healthcare. Maybe it is the doctors, the nurses, the technicians, the support staff, even the engineering staff. They are all coalescing together to deliver one single point, the patient care and the healthcare delivery. It makes the subject complex because multiple people are involved. It also increases the chances of making errors at every single step and at times may lead to chaos. So what can one do to stop this chaos or prevent the errors which could be life-threatening and which could be leading to multiple complications in the form of increased morbidity or even at times mortality? The medications error in US stand alone for a huge cause of mortality. So that we are here at the quality level to prevent those errors which cause morbidity and co. So checklists are one subject. Once we adopt the checklist, we can greatly reduce the errors. It prevents the errors of medication errors, the procedural errors, the wrong side surgery errors, and the other errors. And we can take the performance to the level of Sigma 6, which is my dream, which is my wish, that every healthcare should be performing at a level of Sigma 6. That means making 3 to 5 errors per million operations. There comes the role of this checklist, whether there is a clinical checklist. I must thank Dr. Atul Gawande here, who developed that WHO surgical safety checklist, which was adopted by WHO in 2009, and today finds place at every single institution which is delivering healthcare, and it itself has prevented number of surgical errors across the globe, and has also eased the life of the performing surgeons, performing nurses, performing technicians, and everyone around, including the administrators. So in next few minutes, Dr. Paul Bowie will be delivering his experience and his suggestions as to how to comply with the checklist which are there in every part of our healthcare delivery, engineering, nursing, technicians, compliance, regulatory compliances, and everywhere. So I have a pleasure of introducing Dr. Paul Bowie, who comes from Glasgow. He has over 30 years of experience in directing, leading, and collaborating research, innovation, and education development to improve the quality and safety of healthcare in UK and globally. He also have a portfolio career in the program director in safety and improvement with NHS education for Scotland based in Glasgow. He is also senior investigating science educator with the Health Services Safety Investigations body in the England. He has got a very illustrious career, and if I can read his CV, I think I will be taking enough time for the of the seminar. He gained his doctorate in significant event analysis in primary healthcare from University of Glasgow. He has published over 170 articles in international peer-reviewed journals and also co-edited a book on patient safety and quality improvement in primary care. He is currently working on the next book on human factors for clinical education. He is an honorary professor and a PhD supervisor and examiner in the School of Health, Wellbeing in the University of Glasgow, and adjunct professor at the Queen's University, Ontario in Canada. He has got membership of all the many professional bodies. He's academically, his PhD significant event analysis. He's MSc in applied ergonomics. He's got PG diploma in information management. He's a BEA applied social studies. He has got expertise in many subjects. He's an avid researcher and he teaches the UGs, the PGs, and even the faculty. So I have got a pleasure and honor and privilege of inviting Dr. Paul Bowie to discuss about the role of checklist compliances in quality improvement under the aegis of CAHO and ISQua. So welcome delegates. Over to Dr. Paul, please.
Thank you very much indeed, Dr. Gupta, and thank you to colleagues from CAHO and colleagues from around the world who are online for the opportunity to come along today to present on checklist compliance in healthcare, or quality improvement in healthcare in general. So if I can get my slides sorted.
You can make it whole screen. Yeah, that's
Yep.
done.
That is done. Yeah, good. So Dr. Gupta mentioned about the significant benefits of adopting a checklist approach in healthcare, and how this can potentially reduce risks, reduce the chances of patient safety incidents, and make healthcare safer for patients, but also make it more efficient for our workforce as they go about completing both normal and safety critical tasks. However, it does come with a sting in the tail. So checklist design, checklist implementation, the sustainability of checklist use is extremely difficult. And what I'll focus on today is the evidence around how we do that and outline alongside that what good practice potentially looks like. So we'll look at some of the barriers and successes around checklist adoption in healthcare, particularly around patient safety, but also focusing on some of the socio-cultural issues which have to be overcome if we are to successfully adopt, implement, and sustain the use of checklists in healthcare. And that's an extremely difficult thing to do. And we'll touch on the evidence to explore how and why that's quite a challenging thing to do. So I'm going to signpost you to, and hopefully the QR code works, to a piece of guidance that we developed. We started to develop before the COVID-19 pandemic, but we kind of rushed it through because it would become very, very useful in healthcare during COVID as we all redeveloped our work procedures. So work procedures would be standard operating procedures, safety checklists, our guidelines, our policies, our clinical protocols, as we all responded to the COVID-19 pandemic. Now, the issue is, as we will see, that clinicians, generally speaking, have never been trained to design and to implement, evaluate, and sustain the use of a safety checklist. And they're unaware, largely, I think healthcare is generally unaware that there's actually a bit of a design science that underpins how we actually do that. And so I would offer that given the evidence base that the vast majority of patient safety incidents in healthcare, work procedures such as checklists and standard operating procedures are cited as significant contributory factors. So that's the evidence, I believe, that we have a significant learning need in this area. And this guidance, which I'll come back to at the end, outlines good practice, and it might be useful for those who have an educational role or even a practitioner role in developing or redeveloping checklists and making sure that they are usable and that they are useful. So it's probably best with these talks to actually define what are we talking about? What do we mean by a checklist? And there's a whole raft of different definitions. So there's one or two that I've just randomly selected. So it's a tool to standardise process, to prompt safe practices, and ensure no steps are missed, particularly when we're undertaking or performing really safety critical tasks. It's a useful way also for care teams or healthcare teams to agree and standardise how things are done. And it acts as a cognitive aid because it reduces our reliance on memory, especially in dynamic safety critical situations where following steps in a pre-scheduled way becomes really, really important. But it also has other uses. It can ensure that good practice is being followed. It can provide evidence that we're complying with maybe accreditation standards or what the legislation should say. So it's a kind of multifunctional use potentially. And so we can see there about it can improve patient safety, and we have some really good beneficial evidence around that. We can standardise the clinical processes and tasks that we perform. It can help us to communicate and strengthen team working. And obviously, the most important aspect of this is the whole idea of guiding our decision making from that cognitive aid perspective. And of course, the interlinked issue of reducing error or the potential for error has the anticipated benefit clearly of improving patient safety. But also, as I said earlier, about making things easier for us, making the things safer for us, so the potential to reduce anxiety amongst the workforce and contribute to our own well-being and our own workforce efficiency. So the benefits are quite significant from a multifunctional perspective about what the value of a checklist can be. And so this is the bit where there is a sting in the tail. So when you look holistically at the evidence base around checklists adoption and success, you can see that there is mixed evidence. So yes, there is good evidence, as Dr. Gupta pointed out, of where there has been significant inroads made in reducing various types of patient safety incidents across various clinical areas. And perhaps the most famous example would be the WHO surgical safety checklist. But even the evidence behind that is mixed. So where it has really good adoption, it works very well. It has mixed adoption elsewhere, and sometimes in smaller numbers, there is a disengagement from that type of safety checklist approach. And as we will see, a lot of the issues around this are social cultural. They are not technical to do with checklists per se. They are about leadership, they're about behaviours, they're about convince us of the evidence. So what we roughly badge as socio-cultural issues, challenges, problems, expectations around the use and benefits of safety checklists in general. So here are some self-selected barriers and facilitators, some of which I'm sure many of you will be familiar with. So a number of significant barriers, which the guidance I referred to earlier seeks to address. So the idea of suboptimal design. So not paying enough attention to the fact that any checklist needs to be designed in a participatory way. So the concept of co-design. So it must be designed with the users, and there will be a multitude of potential users from across the multidisciplinary team. All users or representatives of users must be involved in the co-design of a checklist. And as we'll see, as we do see from the evidence, that's very mixed in how we engage with the idea of co-design and participatory design. There's also issues around, resistance and culture and leadership behaviours. So, for example, if we look at senior clinicians such as consultants, some of them believe that the use of a checklist interferes potentially with their clinical freedom. Others see it as a childish intervention. They don't see much benefit in it. They think it belittles their expertise. But there's also more operational issues around the fact that some of the team have never been trained in the use of a checklist, or may not even be aware that one exists. And of course, that even if we try and do introduce them using good practice principles, there are the everyday issues that we all face in healthcare around time pressures and workloads and distractions, which interfere with our ability to reliably use checklists for the way that they're intended. And part of that is around this issue of fidelity. So fidelity is how close do you stay to actually implementing all of the checklist in the way that's been intended. And so what we see from the WHO surgical safety checklist in terms of the evidence is that we can see, much evidence of partial implementation. So the fact is that, some of the boxes may be ticked, some of the tasks may be performed, but not all of them are. And that clearly has a knock-on effect in terms of its success, in terms of its intended use, but also its sustainable implementation. Another issue which we see, and this may be levelled at the WHO surgical safety checklist, is the lack of flexibility. So, context is everything in patient safety. We all work in different disciplines and different care sectors within different nations, countries, cultures, and therefore there needs to be a flexibility about how we understand and adapt and apply the use of a safety intervention such as a checklist. But quite often they come in a very standardized format, which doesn't necessarily always fit the context that we work in. But there's no room for flexibility, so we don't have that adaptability. Now, the upside of all of this is that I've spoken about some of the barriers there, but the opposite is true when it comes to facilitators. So where we have strong leadership, where there's a buy-in around the whole concept of safety culture, of safety checklists and its benefits, and that this is spread to an engaged team, then there's a strong chance of success there. Another indicator is of the prevailing safety culture within a team, or within a department. That is inextricably linked to engagement levels and success levels as well. And of course, people need to be trained in their use, and there's a multitude of different ways that can be done. I've mentioned design. So the fact is that if from the get-go, if you are taking a participatory co-design approach to checklist introduction, then you are giving it a much better chance of success because you have team buy-in and engagement from the very first minute as such. And I mentioned the flexibility, so the opportunity to tweak aspects of a checklist or any safety intervention to suit your specific context is really important. And we need to have a continuous ongoing program of monitoring, audit, and feedback so that we can see if that fidelity issue is being addressed, i.e., we are using the checklist and we're using it reliably in the way that was intended. Another important issue in terms of facilitating success is that we don't want to add necessarily to the workload of those in clinical areas at the sharp end of practice. So as best as possible, we want a safety intervention like a checklist to be integrated within the existing work processes so that it's not seen necessarily as an add-on. Now, these things are easier said than done. They are very, very challenging, and that's part of the issue, or the issues as to why we have kind of mixed success from an evidential point of view around checklist use in healthcare. And here's some other challenges. So I did say there's a multitude of challenges. There are many more, and they're more to do with accessibility of a checklist, to the local policies and cultures in the organisation, to how feasible we believe they are, to the fact that they may affect their own control of our jobs. They may not be designed properly from a usability point of view. And so these are issues that the guide I mentioned earlier on all seek to address. And it shows you that something that on the surface may look like a simple patient safety intervention, i.e. a 1 or a 2-page checklist, actually becomes a highly complex socio-technical intervention with significant social cultural influences, as I've mentioned, which cover many of these different issues here. And that's the challenge of introducing something like a checklist. And hopefully you can see that it's not as simple as we may think it is on the surface, but it's potentially hugely problematic. And for the healthcare teams worldwide that have done it well, then significant congratulations to them because they have addressed many of these different issues. Not only addressed them, they have overcome them as well with significant success. And they are reaping the benefits of safety checklists in terms of reducing adverse events, concerns around patient safety, and so on and so forth. So what does good practice actually look like then? So we've seen the evidence base, we've seen what the benefits are, we've seen some of the barriers and successes as such. But the key issue that I mentioned at the beginning is that clinicians in general are not trained in this area. And so this is something in the roles that I have, I'm trying to embed in undergraduate and postgraduate medical education where I do a lot of work, but also in clinical education more widely. And so we've been involved in developing a lot of educational resource to address this specific issue. So here are some steps that I'll outline. And the first one may seem a bit odd. Do you actually need a safety checklist? That's the first issue to consider. Because what we'll see is that one of the barriers is actually when a much needed safety checklist where we agree that it is needed is introduced, it actually brushes up against other checklists, other interventions around safety, which potentially conflict with it or get in the way of the implementation of something that's much needed. And so one of the things we have to do is be self-critical. Do we actually need a checklist? And typically, where we agree that we do, then the tasks that are being performed are typically safety critical. They might be hugely complex, so that cognitive aid is required, or they might be rarely performed and we can't always remember how to do them and in what steps we do them. Also, we have to address the issue that we may have trainees in our departments, we may have team members who are newly qualified but inexperienced. But also, I mentioned earlier as well, things like compliance. We need to provide evidence of compliance to maybe an accreditor or some other external body that we are meeting certain standards and that the checklist is the tool to provide that evidence. This is a tool that ISQua has recently developed as a form of what we call walk-through, talk-through analysis. And this is a data collection tool known as ISOG, the In Situ System Observation Guide. Now, why am I showing you this? What's this got to do with checklists? Well, part of the issue is that if we want to really understand the use and feasibility of a checklist and where it's going to work, then we need to understand the complexity of the work that's been done and the context in which that work takes place. So we might have to go in situ, we might have to go into clinical areas where we want to use the checklist to better understand the realities of how work is really done, so that the checklist can be designed to reflect how the work is done and not how it's imagined, and we'll come to that in a minute. So this is something we can signpost you to for those who are interested in doing this. And this tool, or this approach, it has a much broader approach in terms of looking at patient safety and quality improvement beyond just checklists. And I mentioned two concepts there, which are really important in the human factors world where I come from. And this is the idea that quality improvement projects and safety checklists in general often involve a lot of what we call work as imagined. And what we really need to do, using the approach that I've just mentioned, is have a better understanding of the work as it's really done. So work as imagined is often what's contained in organisational policies, what's contained in best practice guidance, what's contained in the minds of people who are removed from the sharp end of practice. So they don't necessarily do the same work that you guys do. And this is what we call work as imagined. It doesn't necessarily reflect the reality of how the work is really done at the sharp end of practice. And so there's always a misalignment or a mismatch between these two concepts. And from a safety checklist design point of view, what we really need to know is about both those worlds. Work as imagined, work as done, so that we can design the checklist in a way that better reflects the reality of how work is done. And so there are other issues here around here. So sometimes that the work is done isn't fully reflected because it's a single leader or individual with an interest in the checklist who essentially designs it and introduces it and runs with it. And they haven't captured the multiple perspectives of the rest of the team, who see the system differently. You know, we all see a system differently, and so we need to explore and capture that. That's part of the complexity of design. And so there's a lack of shared understanding, where there's a lack of co-design, and so it's inevitable that there will be failures because of this idea that we haven't explored work as imagined and work as done, and we haven't involved all the users of the checklist potentially. And that's where we come to this whole idea of capturing multiple perspectives. So I mentioned the point that a potential barrier is only one person leading. Now you can't overcome that. That's fine if one person leads, but as long as that multi-team approach is taken, that multidisciplinary approach is taken, we need to understand who's actually going to be using the checklist. When do they use it? What circumstances? What other tasks will they be doing? Are there any conflicting goals in terms of how we actually use this checklist as well? So a lot to contend with here in terms of capturing multiple perspectives and exploring the context of potential checklist use as mentioned. As part of that walk-through, talk-through analysis approach we spoke about there, we need to identify system hazards or issues across the system that are going to impede or act as barriers to the successful implementation of a checklist. And that's why you have to do the hard jobs. You've got to do the hard work when you're at the design phase in understanding all of the issues around the usage and the usability of the checklist, which is in development. So what can potentially act as an impediment to implementation? Is it obvious? It might be obvious to you, but it might not be obvious to others. That's why you need to go and speak to them. So you need to have that shared understanding. And in doing that, we do what's called a systems approach to identifying hazards. And the tool that I mentioned earlier, and another other tool that's coming up here called SEEPS, provide the framework or the basis for us to take a systems approach to understanding the clinical environment in which a checklist will be used. So typically, we're looking at these different issues around people, tasks, the physical and social environment, how work is organised, and what external influences might come to bear at the sharp end of practice and potentially affect or inhibit the use of a checklist. Now, some of you might be aware of this particular framework. It's probably the most famous and popular human factors framework in healthcare. It's known as the Systems Engineering Initiative for Patient Safety, or SEEPS. And this is a practical worksheet that we've developed at ISQua that lets you go into a clinical area and explore and note some of the interacting work system issues which may impact on the design and usability and success of a checklist or any other safety intervention or improvement intervention that matter. So this is something that the work I'm involved in the UK and also internationally, where this worksheet has become very popular. And it's what we call the Swiss Army knife of entry-level human factors. It can be used in many, many different ways. But in terms of helping the design of a checklist, we see lots of different examples of how that's been done. And on the flip side of this worksheet, we have some guidance around, well, what do we mean by task factors? What do we mean by the physical environment? And how can these things potentially, not all of them are relevant, but how can some of these things potentially inhibit the success of checklist design and the introduction of the checklist to try and improve patient safety? So two tools there that we believe are really important to explore and understand more meaningfully those social cultural issues that I mentioned at the top of the session. So we take a systems approach to understanding those social cultural issues. And once we have a more meaningful understanding, it gives us a better chance of designing a useful checklist which will be usable and impactful when introduced into the healthcare setting. We need to make the checklist easy to follow. Okay, so this is part of the science bit. So that in terms of what it looks like, how it's designed, that it's readable, that it's in concise and clear plain language, that we know what font types to use, what font sizes to use in the checklist. We know what colouring to use. We know also, so for example, the classic example you see there is the yellow text on black, which makes it stand out very well. Okay, so that's a good example of what we call contrast in a checklist, so it makes it easier to follow. We need to be very careful about how we use bold letters and block capitals and italics, because they can detract and become difficult to read, especially if we use them too much. We need to think about the whole idea, certainly in English, of using the active, not the passive voice. So there's an example there. The team calculated the drug doses as active. It's much more easier to engage with and understand immediately, whereas the passive voice is the drug dose was calculated by the team. Yes, we can understand it, but it drags on a bit. And so writing in a more active voice is really useful for checklist design. And an important thing here, which I see lots of examples of where we don't follow this, is that we need to remember that if everything is emphasised, i.e. everything's in block capitals, everything's in bold lettering and italics, and it's all spaced together, and it's long sentences. If everything is emphasised, then that means nothing is emphasised. So we need to be very careful about the design of what a checklist actually looks like, and we need to test it out. So this is an iterative base, on an iterative basis. So plan, do, study, act cycles. I won't go into them, but I'm sure many of you in the quality improvement world are familiar with this. It's a way of quickly testing out and getting feedback on whether something's working or not, and if not, how do we change it, update it, put it back into practice, and keep testing it out. So this needs to be done with users, and we need to get their feedback. So, many of you will be maybe, I don't know, you'll be maybe showing your eyes and going, there's so much going on here, but this is what is required, from a patient safety perspective, if we want a checklist to actually work. Okay, there is a lot of hard yards to be get over to make sure that we get success with this. And as I said, to come back to the evidence base, that's why it's so mixed. because where it's failed, we know that those hard yards haven't been covered in terms of the different issues and the different approaches that have to be considered to successfully introduce this type of safety intervention. We need to train people to use the checklist, and there are a number of different ways that can be done. So we need to work out, well, what does the training actually look like? Can it be online? Does it have to be face-to-face? Could we introduce a simple guide, a short YouTube video? Who's the best person to actually conduct the training, or the best people to design and conduct this training? So you probably need somebody to be an educational lead around this, as well as we'll see later on. We also need people to be overall champions for it. But we're always asking, can this person with this level of training and experience do this task using this checklist under these clinical conditions as such? So plenty of food for thought here around the education and training, which again is often a barrier, as we see from the evidence base. And then we need to put it into practice, okay? We need to say, right, we're going to use this for real now, guys, and then we're going to have to monitor its use. But what we often see is different competing checklists, conflicting goals, again coming from the evidence base, where people are expected to do something new around a checklist, but also use other checklists or use other standard operating procedures or whatever the case may be that may interfere with the potential to complete the checklist tasks. There's also an issue around version control. So when we look at both checklists and work procedures in much more detail, in any given hospital, for example, you will see different versions of them. So there's a lack of version control. So there's variability in the up-to-dateness of checklists that are being used in a local area. And so again, another piece of hard work there is around who manages that situation, who makes sure that the most up-to-date version is being used. And so we also know that what we call the spray and pray approach doesn't work. So just emailing out a checklist or putting a poster up ain't going to cut it. You have to do so much more to overcome those social cultural issues. So we can look at other issues such as embedding it in induction, and when people start who are new or who come from training programs, and an issue that works really well from an evidence base, generally speaking, in patient safety is the whole idea of champions. So either a patient safety champion or a checklist champion. So somebody who's there to oversee engagement amongst the workforce with a checklist, but also provide feedback on its implementation status and how well things are going, and giving that feedback on an iterative basis so that we can tweak things as we go along to make it again easier to use the checklist. We need to keep it under review. Again, more hard yards, okay? One of the big issues we have is that you can have the best designed checklist in the world. You can have the team agreeing that it's really necessary, it's really important, and that we really need it. But after a while, awareness sets in. So sustaining its use is one of the biggest failures that we see in healthcare. So we've seen, surgical departments, for example, whereby the surgical safety checklist has been introduced very successfully, but over time that falls off. And so you have to continuously keep it under review. And I'm just getting to the end stage now to try and summarize for you as much as possible what the success factors are with checklist introductions and checklist compliance. So we need to understand that the checklist is actually a technical solution to us trying to solve what is a socio-cultural problem in the workplace. Lot to do with beliefs and evidence, with behaviours and values and so on and so forth. We need buy-in. We need attitudinal changes. We need to remove operational barriers. We need to be creative and adaptive. We need to have that continuous feedback to act on improvement. And we may actually have to redesign our care systems to make it easier for the checklist to be introduced as well. So a lot of issues that need to be considered to support the successful implementation. Now this paper here, and I think this is my final slide, this paper here summarises this most beautifully in terms of, and it isn't just about checklists incidentally, although it's reality check for checklists, it's about patient safety interventions or quality improvement interventions as well in general. So the healthcare team must agree that there's a predefined problem, that the checklist is the right tool for solving it. They must have full agreement on that. It must be co-designed, tested and evaluated with all users or representatives of users. I spoke earlier about the flexibility. You must be able to break it and rebuild it and redefine it for your own context. And you also have to have the feeling that you're not being deprived of the opportunity to apply common sense where it's required. And the clincher is that you will get a change in practice. You'll get successful adoption of the checklist, and sustained use of the checklist is what you're after. That's the goal. You will get that if the healthcare team believes that what you're doing now is better than what you did before. So that introducing the checklist is a better way than the old way of working. So these bullet points here summarise the entire evidence base around the successful introduction of safety checklists and their compliance with safety checklists. So that's going back to a lot of the guidance here is covered here. We can circulate this resource along with the other resources that I've mentioned in terms of the tools to colleagues on the call. So on that note, thank you very much indeed. Hopefully we'll get time for some questions.
Yeah, thank you, Dr. Paul. Thank you very much. You have been very elaboratively given the whole concept of checklist as to how to design, how to implement, what are the barriers, what are the benefits. You have probably echoed my own feeling that it is not a technical issue to design and implement the checklist. It is primarily a social and cultural issue. We need to adopt quality as a culture. And incidentally, the clinicians in a hospital are the holy cows. It is very difficult to tell them anything. They think that they have got the best knowledge in the world, but I believe they are not very good managers. So they are very good adopters as well. And it is a journey which may start with a very baby steps, but then gradually, as the from infancy, you go to the toddlership, you become an adolescent, and a little bit time comes when you are a mature quality systems working. In India, this part of the world, healthcare attrition is a huge issue. So every time you have new people joining the systems, the thing is we are an advantage that now we have got an environment of quality all around us. And the people who join us from the lateral sites, from the other hospitals, from the other healthcare institutions, are already oriented to quality. So our challenges become little less. So that again tells my story that whenever we are evolving and we are evolved to a level, the jobs become easy. The social cultural barriers, they break down. The buy-in has to be there, definitely, 100%. See, if the consultant, the more important is the leaders buy-in. Once the leaders buy-in, then they can direct their teams to adopt. And it is a slow, gradual, evolving process. You rightly very said, must be under review. What I was going to say, that the checklist they evolve over a period of time. It is not a thing written in stone. As your needs change, the checklist also change. The WHO surgical safety checklist can give you a guideline. Okay, go through these things. Sign in, time out, sign in, sign out, time out. Right. But then you can adopt to your own systems. You can reduce the number of columns, you can increase the number of columns as per your needs. That should be the thing. So with these words, I highly appreciate your thorough knowledge and a very beautiful way of explaining things in a very, very simple words. And I'm very sure that all the attendees to the seminar will be hugely benefited. So with these words, I throw the session open to all the Q&A and whatever questions people are having in mind can raise their hands or type it. Then we can ask them to speak up uh, turn by turn. The house is open. Any questions?
Rakesh, you can read some of the questions which are there in the Q&A, and you can throw
Chat
it.
box.
Yes. First of all in Q&A, and then maybe in chat bot, first of all.
Q&A should be सर आप एक बार देखो कहाँ होगा Q&A मुझे आइडिया नहीं है.
Okay, so there is one. Can hospital prepare or design its own safety checklist based on
Yeah,
daily
definitely.
practices and practical way? That's exactly what Paul said, that yes, you have to do that. There is one from Vaizan Khan. How can healthcare organizations ensure sustained checklist compliance beyond the initial implementation phase, especially when staff perceive checklists as additional workload rather than a quality improvement tool. I think all this has been already covered by him. And
Yeah, I think
yeah,
the holy grail there is that
yeah,
to build it in so that it's not additional workload, so that it's part of normal routine.
yes,
And that's the difficult bit. How do you work that out? Because if people see it as additional to their workload, then it impacts on their well-being. After a while, they'll become irritated and frustrated, and they'll see it as a hassle rather than what it's intended for, which is a very well-meaning patient safety intervention. So we need to make it easier for staff, and that's, as I said, that's the holy grail. How do you integrate these types of interventions within normal daily working practices so that they're not add-ons?
May I add here, it is not an obsession to their work. It is makes the work process easy, smooth, without errors. And the junior team will not be reprimanded for any errors once they do the jobs nicely. So it is the way of working. It is the culture which everybody needs to adopt. We have a concept of read my mind. The consultant will say, I will not tell you anything. Read my mind, what I need, what I want. In OT, he will go to the OT without telling what equipments are required. Middle of surgery, he'll start shouting. I need this one. Sir, why didn't you tell us this before? So a checklist will ensure that whatever I require during a surgery, whether a suture or a small instrument or a specific instrument, I will tell beforehand. The team will be happy, patient will be safe, process will be smooth. So everybody is benefited. Once the team understands this concept of benefit, that they are the beneficiary of adopting a checklist, their life will be more easy and more smooth. The adoption becomes easier. It's not a hindrance to their work or an additional work. It is the work which they need to do. Yes, sir. Any more
thank you.
questions?
Can I ask a question?
Yeah, yeah,
Yeah,
Samina, go
sure.
ahead. You.
Thank you. Thank you, Dr. Vijay and Dr. Rakesh, for bringing Dr. Paul Bowie and giving us such a fantastic webinar. Learning a lot from him. I'm Dr. Paul. I'm a keen student of standard operating procedures and checklist, and Dr.
Yeah.
Vijay had given me this opportunity long back to talk about standard operating procedures. So I just want to share my observation in my organization. We've realized that sometimes checklists become unbearably long,
Hmm.
and it's difficult for a person to even look at it and read through it. And we realize that some of those important key points, key areas of patient safety, and those areas where staff or teams usually miss that. So those we have now encapsulated into a different form of checklist known as do not miss list. So we have shortened our checklist and made these do not miss list, and all at all our workplaces at our hospital we have these do not miss lists. So what is your thought about? I think I would like to ask all the three of you, all stalwarts in quality, that what do you think? Is it the right thing? It is helping us. We are an IK organization, but do you think it does make sense what I'm trying to tell you? Yeah.
Absolutely makes sense. So on the guide that I mentioned earlier, it's at pains to point out that you know long checklists and even longer explanations of the content of what's in a checklist are just bound to fail because people just don't have the time. They don't have the bandwidth to read and respond in the way that it's intended. So chunking things up into what is perceived as the most safety critical things to do, i.e., do not miss this, makes eminent sense. The good thing about it is hopefully is that it's the users of the checklist that have helped you to design that. It's that they've come to the conclusion, hang on a minute, guys, this is the most important element of it, or these are the most important elements of it. And so that's part of the iterative design, introduction, use, feedback, adapting it again, testing it out. And so at the end of the day, if it's been used in the way you're describing, Doctor, that's fantastic because with that engagement from your team members and their ideas contributing to this, that's a significant contributor as to why it will be welcomed, introduced, and sustained in practice. If it's imposed on them, it's less likely to be sustained in practice.
Dr. Samina, may I add? What you say is a do not miss. You can add the same things in the one single checklist with the emphasis, either the form of making it bold or color coded. Because if you have more number of pages to go through, the checklist becomes cumbersome. And it is always an evolving process. The moment you find the checklist is long, unsustainable, you can modify it, make it to the point, whatever is required as per your system's requirement, and where the majority of the stakeholders can put in their ideas. Okay, this is important, should be kept. This is less important, can we delete it? So it is a process which evolves with the passage of time. The more you use it, the more comfortable it becomes. Similarly, the people now using the quality systems in the particular organization is significant. Initially, it used to be 10-20%, then it became 40-50%, today it is 70-80%. If you have people of a population of around 80-90% who are quality oriented, they take quality as a culture, they take quality as a journey, your job is relatively easy. And then the new people who join can always fall in line and they do it with the pleasure. The thing is, should not be penalizing. They should realize these benefits which everybody is having, other than the patient. My life becomes easy if I'm a checklist. Over to Dr.
Oh,
Paul, sir.
So I will just say that just to tell you guys that Samina is one of our original thinkers. So what I appreciate about Dr. Samina is that all the time you are thinking as to how to make it more relevant, how to kind of make innovations. And so I would congratulate you anyway, because, you know, doing it for ophthalmology and doing it for different things will probably require different strategies. But most important thing for me is that we require people like you who should be thinking all the time. It's not merely copying a concept, because the moment you start thinking that how am I going to do this to improve patient safety and quality, I think that's what is required. So congratulations. I like what you are talking about. Yeah.
So nice, sir. Thank you. Thank you. We have learned from you, sir. Thank you very much.
Thank you. So any other question, or otherwise? So the participants can kindly fill the feedback stuff. Yeah. And can we now come to the, we can give our presentation of a certificate to Dr. Paul Bowie. So
Yeah,
thank
sure, sir.
you.
Please go ahead.
So thank you, Professor Paul Bowie,
Thank
for
you.
this excellent webinar that we have witnessed. You know, this is the 59th CAHO-ISQua webinar, and we are indeed proud that you did it. Thank you so much. It will be, of course, mailed to you. So thank you so much.
So thank you for the
And
opportunity, and I
yeah,
fully
and
appreciate that. Thank you.
yeah, and thank you, Dr. Rakesh Gupta, for
Yeah,
this
welcome, sir.
excellent
Welcome. Thank you
moderation.
for giving us such opportunity.
Yes, excellent moderation. Go ahead. What is the next thing on the agenda, Rita? Yes, so also to introduce you, the 60th, that is 5 years, ladies and gentlemen, of completing our CAHO-ISQua webinar, which is establishing a clinical governance framework in hospitals. Extremely important topic, and the speaker is Gillian Giles, who is the Director of Clinical Governance in Australia. So do join on the first Tuesday of every month, as we know, and a lot of hospitals are now celebrating it as a monthly quality meeting. And today also, this particular meeting was broadcasted by Vijaya Medical Educational Trust in Chennai, Mehta Hospital Chennai, Ganga Hospital Coimbatore, Medica Super Speciality Kolkata, Fortis Hospital Punjab, Rajagiri Kerala, Baby Memorial Kerala, Bethany in Meghalaya, Sri Ranga Hospital Chengalpattu Tamil Nadu, AJ Hospital and Research Center Mangalore, Bombay Hospital Mumbai, Nirmal's Eye Hospital in Tamil Nadu, Jabalpur Hospital and Research Center, Madhya Pradesh, Christian Medical College, Vellore, CMC again, Ranipat Campus, Institute of Neurosciences, Kolkata, West Bengal. And also Tata Steel Medica Hospital, Nazareth Hospital in Shillong, Meghalaya, Sehgal New Hospital in New Delhi, and ILS Hospital, Damdam, Kolkata. So congratulations to all these hospitals for taking this initiative. So thank you so much. We are now, some of the upcoming activities are the hospital infection control program on the 8th of November. This is virtual. On 15th is the NC closure, nursing quality improvement on the 15th of November. We have training programs on nursing maths on 29th November and hospital infection control advanced program on 29th November. Then we also have a certificate program in biomedical equipment management on the 29th November at KIMS Secunderabad. This is an on-site program. We have a masterclass series on blood bank and laboratory medicine and empowering clinical excellence on 7th November from 4 p.m. to 5:30 p.m. Online certificate program in quality management for healthcare professionals, and the batch starts from 15th of November 2025. We have the continuous diagnostic education series, and we are going to reach a phenomenal milestones in that. As you can see, the 98th CD series is being announced, 99th CD series has been announced, and 100th is going to be there. So this is a phenomenal, I think, milestone of 100 of the continuing diagnostic education series on the topics that you can see on the screen. Next, please. And then we have the excellence programs on endoscopy, safety, and facility evaluation, which is EndoSafe in association with ASP. Also, the infection control and microbial stewardship compliance, I comply in association with Diversity, and that is for enhancing safer care through best practices. Next. And I will request all the people, whoever can come, please do join this very, very important conference. That is the 10th edition of CAHO Tech, which is to bring technology and healthcare together. This is where you're going to see how technology will impact and solve the challenges in healthcare. This conference is on 16th of November, and on 15th of November, you will see the presentation by the startups as well as the early adoption of technology or innovation by hospitals. So do make it a point to come to Bhubaneswar in Odisha and take that, I would say, opportunity to do visit a wonderful state of Odisha, visit Jagannath Puri, and do make it a point to be there, please, on the 15th and 16th of November. So also, just to let you know that in January, we are going to have our very major annual conference of diagnostic people on 24th and 25th of January at Indore. So block your dates. And of course, CAHO-Con, which is the in the 11th, 12th of April in Chennai. So thank you. Block your dates again. And thank you so much for being with us today here. Thank you.
Yeah.
Thank
Bye,
you.
everyone.
Thank you, sir.
New dawn, a new horizon. Of healthcare delivery and patient safety. have a goal. A noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, CAHO, your healthcare companion. CAHO, standing right by your side. CAHO. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare.